I am Dr. Lorance Peter. I am a gastroenterologist working in Bangalore. I work at Manipal Hospital as a gastroenterologist and interventional gastroenterologist. Gastroesophageal reflux disease has been my interest for last more than a decade, in which I have looked at various factors of affecting this disease and the treatment outcomes. GERD, or gastroesophageal reflux disease, or what we say as commonly as acidity or reflux, is one of the very common disease affecting many of our people, especially people who are little obese, smokers, who take alcohol. You suffer from this, and many of us would have had once or twice heartburns. But when do we call a patient is having GERD is when these symptoms caused by reflux of the stomach contents into the food pipe causes symptoms, and which is bothering to the patient. These cardinal symptoms of gastroesophageal reflux disease or GERD, apart from the heartburn, the others many people feel are the sour irritations or the sour fluid coming into the mouth, especially when they bend down or when they lie down after meals. In the reflux disease, the symptoms are more when you after food normally, and when people eat and when they lie down, the symptoms becomes more. Occasionally, the patients may feel other symptoms like chest pain, difficulty to swallow, or what we call as dysphagia, and with the food getting stuck. These are normally a symptom of complications of the normal GERD. Uncomplicated disease of gastroesophageal reflux disease has symptoms of heartburn or regurgitation. There may not be much of signs when you look at the patient from a doctor's perspective. There may be hardly any few signs. How do we diagnose gastroesophageal reflux disease is not by major tests. It is a diagnosis of symptoms. If a person has predominantly symptoms which are like heartburn, which is attributable to the coming of the gastric or the stomach contents into your food pipe, then the patient has GERD. There are various tests which doctors order to find out whether the patient has some complications or what are the other conditions which are predisposing this patient to gastroesophageal reflux disease. The common tests may include an endoscopy or gastroesophageal endoscopy, which look at your food pipe, stomach and duodenum. The main advantage of an endoscopy is that it helps to see the extent of the damage caused by the reflux disease to your food pipe, and it can be graded as different grades, which helps the physician to determine whether this patient requires a long-term treatment or we can give a short-term treatment or a need-based treatment. It helps that. It also will look at complications like Barrett's esophagus, obstruction to the duodenum, or any gastric emptying problem. All those things can be tested. The physician or the doctor attending to a patient with a GERD may order some tests to look at reasons for obesity, diabetes, thyroid functions. All those conditions will be also looked into. In some patients, GERD can present atypically with a respiratory or lung-related problem like aspirations, pneumonia, asthma, bronchitis, chronic cough, and even tonsillitis and dental problems. Even though these issues are considered as a part and can occur in patients with reflux disease, the reflux disease causing these problems form only a minority of patients. So how do we treat these patients? And we usually treat by giving acid suppressants, because acid produced in the stomach is a major cause of symptoms and injury to the food pipe. So the major group of acid suppressants what we use is a drug called proton pump inhibitors. They form the key or the cornerstone for treatment of GERD. The proton pump inhibitors there's various brands, various generations of molecules like omeprazole, pantoprazole, lansoprazole, esomeprazole, and rabeprazole. There are many drugs. How do they act? they inhibit the secretion of acid into the stomach once it is conceived, and majority of them acts for 24 hours. There are later newer generation of PPIs which has less side effect profile and longer duration of action and are more efficient acid suppression medications. So what are the complications of when we give long term? Many of the patients will require treatment for long term. So what happens to them if we give them long term PPI? There are some concerns of loss of mineral density in the bone and fractures and and prolonged acid suppressions causing recurrent infections, but majority of them doesn't happen, and it's quite a safe drug to take for long duration provided it is under medical supervision. There are other drugs like sucralfate or even prokinetic drugs like domperidone and levosulpride, and also used to treat reflux disease. The exact role of these medications in common GERD is not well established, but in special situations where there is gastric stasis or there is stomach empties slowly, it may be worthwhile to consider these medications. So majority of the patients, we diagnose GERD by symptoms and they are treated, and many of them will require endoscopy to look at the extent of damage. Are there any special tests we do? Yes, we do special tests to look at what is the exact cause of GERD in such patients. This may include esophageal motility studies like manometry, and we can also document the amount of acid reflux which happens in a patient by doing a 24 hours ambulatory pH monitoring. These are not done routinely for every patient. In selected patients in whom the diagnosis is a doubt, or when we need to plan treatment or change strategy, like we need to surgery or anything need to be done, then we have to do these tests. And what is the surgical option we have for GERD? Yes, there is a surgical option. We can do a surgery called Nissen Fundoplication, which can be done laparoscopically without much complications, and this is done in patients who usually do not who don't want treatment with the medications for longer time, or they have complications of reflux disease, and patients who are not unable to take the medications. So majority of the patients respond to medical treatment, and only a minority will require Nissen Fundoplications, which is quite safe if chosen for the right patient in the right time. What is the type of diet which a person with the reflux disease should be taking? They should be taking small frequent meals and never completely filling their stomach, so that their stomach is partially empty and they don't reflux all the time. Eat dinner early and at least give 2 hours of gap before you lie down, and keep the dinner light and keep the last meal of the day light. Avoid too much of oily, spicy, rich food which causes more reflux disease. Avoid smoking, avoid alcohol. If possible, sleeping with the head end of the bed raised by around 6 inches or half foot by putting some wooden blocks or bricks under the head side of the cot is a good idea. It gives you a good gradient for the reflux to come down, and it will be better for the patient with these symptoms. But does this alone help? No. When you do these things along with medications, it helps a lot. And obviously, if you are obese and overweight, weight reduction is very important. That reduces the need for medications and symptoms to a great extent.